Very good. So again, welcome everyone. My name is Hiva. I'm a family nurse practitioner with Archer Review, and today is our free webinar on reproductive health. We're going to talk about contraception, and then we're also going to talk about prenatal care in our pregnant moms. Before I get started, as everyone's joining us today, I'm going to give you some time to trickle in. We just want to quickly go over all the different products that we have here at Archer. You probably know of some of them because you're here today for the webinar. So you've probably heard of some of it. I want to make sure you've heard about all of it so that you can really tailor what you need for your studying, for the support that you need in your training. If you're still an NP student, a lot of students use our Archer products through the course of their NP school, and then use our Archer products to help prepare for the boards and also gain that support once you've passed your boards and you're entering into your first clinical role. So I want to make sure you know about all the great stuff, and we're always open to suggestions. So if there's anything that you would like to see, maybe in future webinars, you can always contact us and I'll show you how to do that. And we'd be happy to put something together for you. So I'm going to be pulling some questions from our question bank today. We have a free trial in our question bank, over 1,600 questions. And basically, this is a question bank that simulates both the ANP and ANCC boards and really helps you. The more you practice, the more you learn from those rationales, really helps you by diving into those sections that you need a little bit more work on. It'll give you a readiness predictor. So I really encourage you to try the free trial if you haven't already. But it's a really nice way to start your studying for your boards if you haven't already started, and also support you in your studying if you're really getting deeper into it. We also have our on-demand videos, over 1,600 hours of content. So that's a lot. You can watch all of it. We go in depth from A to Z on everything that could be covered on your boards exams. And then we break it down to little bite-sized videos. So if you don't need to watch all 16 hours, you can just go directly to the sections that you need on hypertension, hyperlipidemia, contraception, whatever you're looking for. We have a combo product where you can kind of bundle this question bank and on-demand together. And then we have another product called our Sure Pass, which bundles our question bank, our on-demand, as well as our live reviews together. And those live reviews are 3 days of live review. So it's me and other instructors, and we present to you live, and we go through all the different topics, all the body systems, everything that you need to know for your boards, and we're available to you live. So you can ask your questions live and really dive deep into the content. And if you purchase it through the Sure Pass, you get the video recordings for 30 days after the live review. Our next one's coming up mid-November, so don't miss out on that one, especially if you're thinking about sitting for your board sometime in December. Our live review after November is not going to be till January, so I really encourage you not to miss that one. And then we just launched our Sure Pass Pro, which is all this great stuff plus some mentoring sessions with us as instructors. So all really great products. See what fits your needs. You can kind of play around with it. You can always upgrade if you wanted to start small and then kind of as you like it, upgrade. And then I wanted to point out our pass guarantee. So I don't know any other product out there that has a pass guarantee, and I wish it existed when I was in NP school, because I think that takes a lot of the weight off. You're like, okay, if I don't pass, I don't have to pay all this again. I can just go back to the company and they will make sure that they give me the support I need to sit again for my boards and pass. Though we don't really get many people needing to retest, but it's just a nice little reassurance for yourself in your heart if you're, a perfectionist like I am. And then, of course, our social media. That's probably how you heard of this free webinar today. So I really want to encourage you to be following us on social media. So our Instagram and TikTok pages, we do a lot of giveaways. I think they gave away a stethoscope and scrubs and Sure Passes and mentoring sessions. So you definitely want to make sure that you're following us on the social pages. And then I want to bring your attention to this Facebook group. So if you're watching us on Facebook, you already know we're on Facebook Live right now. If you're watching watching us on Facebook, you already know about our Facebook group. If you don't know about it, I really highly encourage you to go and join. This is where you get a lot of free content. So this webinar will be recorded and posted into our Facebook group. You can access all of our free webinars all hour long. We do about 3 a week on different topics, all different topics. So this is a really great space to go not only join the community of other NP students and newly graduated NPs, but also get all that free content that's available to you that maybe you hadn't seen before or want to go back and revisit. And then, of course, this is our email. You can email us directly. Like I said, if you have any questions, any thoughts, suggestions, anything you need, we're open to it. And we definitely want to make sure we're supporting you. And you can always scan our QR code to get to the page for the nurse practitioner products that we just talked about. All right, so we're about 5 minutes in and it looks like everyone's joined us. So welcome, welcome. We're gonna go ahead and get started on the content that you came to talk about today. And it's gonna be reproductive health. So I'm gonna focus on contraception and then prenatal care as well. Now, if you've joined any of my webinars in the past, you know that I like to tell you to keep your chat box open. I'm going to be asking you questions. We're going to be engaged. That's how we learn best. It's kind of hard on these platforms where we're not in the classroom together. So I really try to mimic that by having you ask your questions. And I'll ask you questions as well so that we can really keep that engagement going. We do have some support in our chat. Our lovely, it looks like both Miss Jada and Morgan are in our chat supporting us today. So we definitely have a lot of help in the chat section. So ask your questions right away, and then we'll have a Q&A at the end as well. And then, of course, if you've watched my webinars, you know I always like to start with the anatomy. If we know the normal, this is the best piece of advice I was ever given as an NP student. Once you know the normal, you can then identify when something is abnormal, right? You don't have to know what it is, but you just want to always make sure that you go back to the normal. What's the anatomy physiology? What's the normal anatomy physiology of what I'm looking at? And then you can help identify the abnormal so you begin the investigation. So I want to make sure we're all on the same page. We're going to do a quick little review of the anatomy and physiology. So for the purposes of today's lecture, we're talking about a female born with female organs. So let's look at the female reproductive organs. We generally are born with 2 ovaries. These ovaries house thousands of follicles, and we'll get into that in a minute. And that those follicles or those ovaries help release that mature egg during the menstrual cycle. That mature egg then goes out into the fallopian tube, and that's typically where fertilization happens if the sperm successfully meets the egg in the fallopian tube. Then it goes ahead and implants in the uterus. The uterus is our muscular organ where that fertilized egg implants, and then also the developing fetus then grows during pregnancy. We also have our cervix and our vagina. The cervix is like the gateway is what we call it. It allows that sperm to enter the uterus and then also helps guide the passage of the menstrual flow during menstruation. And then the vagina, you can think of that as our birth canal. It also helps facilitate that sperm towards the cervix and into the uterus, and then it also helps serve as the exit point for our menstrual flow. Now, with the menstrual cycle, I want you to put in the chat, how comfortable do you feel with this menstrual cycle? And I want you to be honest, on a scale of 1 to 10, how comfortable do you feel with describing the menstrual cycle to somebody in your class or a patient? Give me a scale of 1 to 10, 1 being not comfortable at all, 10 being extremely comfortable, the most comfortable you could be. Where are you guys at today? Okay. I'm seeing some mixed responses. Yeah. So I'm seeing some people kind of like fairly confident, some people not confident at all. I will be honest, I was not comfortable at all. I think I studied it. You always have to go through it in nursing school. But then when I got to clinical practice, I was like, what does this have to do with the oral contraceptive pills that I'm going to prescribe? It just all seemed really daunting. So I was like, okay, let's talk about this. Let's make sure that we're all on the same page. And it's actually not that hard. We're going to hit some highlights today so that you can all feel comfortable moving forward with what we're talking talking about with the pharmacology. And then I have a question from Leo. Are we able to access recordings after this? So yes, so remember that Facebook group, and I'll put that slide up at the end too. We definitely want you to join our Facebook group so that you get access to all the recordings, including today, and all our free webinars in the past as well are all on there. So I'll go ahead and put that link in at the end of today, and maybe Morgan, you can copy and paste that link for us too into the chat, but we'll definitely go over that. Our Facebook group is the best way to get the recording. So great question. Okay, so going back to the menstrual cycle, it's okay if you don't feel confident. Let's hit some of the highlights. I'm going to help you feel more confident about it. So the menstrual cycle can vary. It varies from 20 to 35 days. We're going to look at the average menstrual cycle, which is 28 days. And so day one usually starts on that first day of that menstrual phase, so the shedding of that uterine lining. So each cycle begins on that first day of menstruation. Then those first 14 days, or day one to ovulation, is typically our follicular phase. This can vary. It doesn't typically take 14 days. The biggest thing to know about that follicular phase, so remember we talked about it, the ovaries house thousands of follicles. So in your follicular phase, you have a lot of variation in your estrogen. Estrogen is the predominant hormone in that follicular phase. And what's happening is that the estrogen is working with this negative feedback loop to help mature those follicles. And then it dips. The estrogen actually drops to allow for some of those follicles to die off, and then it surges again to allow for one follicle to deliver that mature egg. So a lot is happening during that follicular phase. What you need to know is that estrogen is the dominant hormone in that follicular phase, and it can vary. It's not always that 14 days. The surge of FSH and LH is what makes ovulation happen. Ovulation is the goal, so the egg is released. Remember, it's getting released into those fallopian tubes, and then we enter our luteal phase. So the luteal phase, the predominant hormone during the luteal phase is the progesterone. And so what's happening there is that hormone helps optimize that conception. The luteal phase is always 14 days. It's that follicular phase that varies a little bit. So knowing those two things will help you, especially as we're talking about those combined oral contraceptive pills. We have estrogen and progesterone at play here. All of this, so those high estrogen levels really help with conception. So it thickens the endometrium. It does a lot of other things. So it thickens the endometrium in that uterus. It changes the consistency of the cervix to make it more hospitable to the incoming sperm. So it's really playing a vital role in all of that to help make pregnancy successful for our patients. But what are we talking about when we want to prevent pregnancy, right? So right now we're going to talk about the types of contraception to help prevent pregnancy. Obviously, some of these methods are used not just for contraception, so we'll talk about that and think about that as you see that on the patient's medication list. If they're on something that's not necessarily for just contraception, but for today's purposes, we're going to talk about the types of contraception so we can prevent pregnancy. That's what we're going to talk about. We have our barrier methods, our hormonal methods, and our long-acting reversible contraceptive methods, or our LARCs, as they're more commonly known. And then prior to starting any of these methods, the CDC does recommend that you do a pregnancy test, making sure that our women are not pregnant before starting them on any of these hormonal methods or our LARCs. And then doing an STI screen, we want to make sure we're doing a PAP if the patient is of age and due, and then a pelvic exam if we're doing those intrauterine devices as well. So we're going to start with our barrier methods. This one is the most commonly used method of contraception, probably because it's the cheapest and it's readily available. In a lot of clinics, it's free. We do give them out to patients depending on the patient population that you work with. Male condoms are the most used, and what we like about male condoms is that it also helps protect against STIs. So that's really a nice added bonus. And I'll talk about this once we're talking about those LARCs and talking to our young young females about using barrier methods as an additive as well to help protect them against STIs. But basically, with male condoms, it does prevent pregnancy in about 87% of the time when used properly. And we'll talk about that because you might get questions on the board like, what's the most effective, right? And so we want to look at how likely is it to prevent pregnancy. So this is about 87% if used properly. You also have diaphragms and cervical caps. Diaphragms do need to be, both diaphragms and cervical caps need to be fitted by a practitioner who's been trained, like a gynecologist. So that's something to be aware of if you're talking to patients about this. Typically, you place these inside the vagina to cover that cervix. Remember, it's acting as a barrier method to not allow that sperm to enter. And then the diaphragm and the cervical cap are just different shapes. And then you do want to insert that spermicide before intercourse. And it has pretty similar, about an 83% success rate when used properly. So about 17% failure rate. Am I doing that math right off the top of my head? I think so. Then we have our contraceptive sponges. So these are not as popular. If you've ever seen that Seinfeld episode where Elaine's talking about the sponge and how it got discontinued, they did get discontinued in the 90s. But now today we have what we call a Today sponge. And so it's not as popular, but it does exist. So you should know about it in case patients do come in asking about it. What it does is it blocks that cervix, similar to a diaphragm or that cervical cap, and then it could be left in for up to 24 hours, and it contains that spermicide. Typical failure rate is about 14 to 27%. So you can see that that failure rate is starting to go a little bit higher as we're moving away from that male condom, right? Female condom also helps prevent, acts as a barrier method, helps prevent that sperm from getting into the cervix or through the cervix. You can buy these over the counter. They can be inserted about 8 hours before sexual intercourse and also do help prevent STIs, which is great to talk to our patients about. Basically, biggest takeaway with barrier methods, they do have a high failure rate. So you need to be aware of that. And they can be used as an addition to other methods, and they are recommended for STI protection. And there are programs that provide them for free to our patients. Now we're going to talk about hormonal contraceptives. I think this is probably the biggest thing that trips people up. What do you prescribe? When do you prescribe it? How do you prescribe it? You can see here, there's so many types of hormonal methods. So there are pills, patches, hormonal vaginal rings, injectables, LARCs, IUDs, and implants are included in that LARC. So these are all huge categories, and we'll talk about them. Again, scale of 1 to 10, how are you feeling with your hormonal methods, with prescribing hormonal methods? 1 being not confident at all, 10 being super confident. Let me know. Okay, I know there are a lot of you guys out there, so don't be shy. How are we feeling? I'm going to take it as you guys aren't feeling very confident. That's why I'm not seeing you're rating yourself on the scale. Ooh, Lena, I've seen your name before, and I think you already took your boards. I'd love to hear a little bit more about you or in the Q&A, but I'm seeing very confidence from Lena. That's great. Anybody else feeling really confident like Lena, or everybody else feeling less confident? It's okay. I did not feel confident at all until I started working in this space. So and I could see for myself, I'm a visual learner, so I could see those implantations and it made a lot of sense to me. I could ask questions, started prescribing it, so that all the experience does really help. Okay, I won't put you guys on the spot anymore. Let's get into it. So let's talk about our pills first. This is the first one I really want to focus on because it's going to be the most common thing that you're going to do in an outpatient primary care setting, unless you do work in a clinic, which does deliver other methods as well. So there are many different types of pills. There are brand versus generic. Not all of them are made the same. We're going to focus on the 2 different categories. You have ones that contain estrogen and ones that do not. So we have our combination oral contraceptive pills contain estrogen and progesterone. And then we have our progesterone only, most commonly known as the mini pill. This talks about our combination oral contraceptive. So you have monophasic, biphasic, triphasic. What does all that mean? Remember, we talked about that menstrual cycle. We talked about that follicular phase. It's your estrogen levels going up and down to help support that follicle into becoming a mature egg. And then we have that luteal phase. So that's what it's talking about. So with monophasic, you have about 3 weeks of active pills. And that's all the same dosage of hormones, does not vary at all. And then you have 1 week of inactive pill. So when your patient is on an oral contraceptive pill, they're not actually ovulating. So we need to mimic that 1 week of shedding, uterine line and shedding. So we call that withdrawal bleeding. And that's why we do 1 week of inactive pills. So with the monophasic, those 3 weeks, the dosage of the hormone is the same. There's no variation in the estrogen and progesterone levels. And then you have 1 week of withdrawal bleeding or inactive bleeding. With the biphasic, you have 2 weeks with the biphasic, you have slightly increased progesterone levels about halfway through. So it's trying to kind of mimic our natural cycle. And then again, you have that 1 week of inactive where you get that withdrawal bleeding. And then with the triphasic, that's the one that's most natural because you have variance in the hormone dosings for each week. So it's kind of trying to mimic that cycle that we have. Again, we're not ovulating on these pills, but it's trying to mimic the hormone levels. So each week is going to be a different variant of the hormone. And then you have that 1 week of withdrawal bleed. When you have patients taking oral contraceptive pills for contraception, but you also are thinking maybe this could be a good hormonal acne solution. So if you listened to my acne lecture last week, we talked about combination oral contraceptive pills being a good option in our patients with hormonal acne. The triphasic is going to be the best for them. It's going to be the most beneficial because, again, it's really trying to mimic our natural hormonal cycles. You do want to talk to patients about how to take these pills, and we'll talk about that in a little bit. Pregnancy prevention rate is over 90%, so a lot better than just those barrier methods alone. It does not protect against STI, so that's going to be really important. And it has a lot of other uses. So if you have patients who have really heavy menstrual cycles, typically with oral contraceptive pills, it does lessen the bleeding during menses, so it could be a really good option. We talked about using it for hormonal acne. That's also a good option for patients. And then also if patients have really bad PMS symptoms, like during their cycle, they're experiencing a lot of like mood elevation and changes. These could be also a really good way to help kind of tone down those fluctuations in their hormones and help reduce some of those PMS symptoms for them as well. But again, biggest thing to talk to patients is about taking it and taking it effectively so that it works. So it's effective against preventing pregnancy and also reaching those other goals that we just talked about. So with oral contraceptive pills, you do want to take them daily. The nice thing about the estrogen and progesterone combination is that it doesn't have to be at the same time every day. We'll talk about the progesterone only pill. You do have a very narrow window with that. But with these combined oral contraceptive pills, as long as they're taking them daily, it's effective. There are medication interactions, and we will talk about those contraindications as well. So you want to be thinking about that before you prescribe for these patients. But it's a little bit more flexible with that window. So as long as they're taking it every day, we're good. Some contraindications to think about for oral contraceptive pills with estrogen in them. Tell me in the chat, what is the biggest thing we worry about? And it's on your screen, so I'm giving you a little freebie here. But what do we worry about with that estrogen in our oral contraceptive pills? What do we need to be mindful of before we prescribe? Yes, you guys are awesome. I love the engagement today. Yes, yes. You guys are getting it. So we really need to be worried about clots, DVTs, but basically clotting risk, right? So we need to make sure we're screening every patient before we start them on these oral contraceptive pills. I really like the CDC contraception app because you can go through your patient's history and it gives you evidence-based recommendations on what's the best form of contraception for that patient to help minimize their risk of having adverse effects. So it's really nice. But let's talk about these absolute contraindications. So with the combined oral contraceptives with that estrogen, we really do want to make sure that we're ruling out any increased risk for clotting in these patients. So any conditions that can increase their risk is a big no-no. So that means, do they have a history of liver disease, cardiovascular disease? Do they have a history of autoimmune disease? So lupus is listed here, but any kind of autoimmune disease actually does increase their risk for developing plaque in their coronary arteries. So that to me is a big no-no. So if they have any other autoimmune conditions, that's not going to be a straightforward oral contraceptive pill option for that patient. Also, anything else, like if they're a smoker, that increases their risk. Over the age of 35 increases their risk. Do they have migraines? Migraines for me are an area where I get really uncomfortable because I want to know who diagnosed the migraines, who's managing it. A lot of times migraines do not get diagnosed properly, so they could be having migraines with aura and they might not realize it and think they don't have any migraines with aura. So for me, migraines, I want to dive a lot deeper. What are these headaches? How do we diagnose that? Who diagnosed it? How are we managing them? And is this a contraindication for this patient? We talked about other conditions that increase that stroke risk. And of course, any type of cancer certainly increases that risk for clotting. So ovarian, breast, endometrial, definitely big no-nos in these patients. Now, the gray area, this is what we always you have to use your clinical judgment, and where that app comes in really handy because it'll give you evidence base of what's the best form of contraception for that patient. Any age smoking, so not just over the age of 35, smoking does increase your risk. It thickens your blood, makes it more viscous, does increase their risk for blood clots. We talked about those migraines without aura. Again, you want to dive deeper into their migraine history, hypertension, sedentary lifestyle, immobility. We all know that from our nursing inpatient days, right? We want to make sure that we're getting those patients moving, avoid those DVTs and those blood clots. But if that patient does have a sedentary lifestyle and they might not be a good candidate, right? So we want to educate our patients. If we feel like they are good candidates, we still want to educate them on the warning signs of blood clots and DVT so that they can catch it early and come in before it develops into a PE. We also want to talk to them about signs of stroke, and then we want to follow up with them. We don't want to just prescribe and say, see you later, and just automatically refill it, right? We want to make sure they're coming back in within 2 to 3 months. We're talking to them about adherence. Are they taking the pill? How are they taking it? Are they compliant? Is it working? Is it effective? Are they having any side effects? And then rechecking their blood pressure and making sure that they're not developing hypertension or any other warning or risk flags for those clots. Awesome job. The biggest thing that tripped me up going into clinical practice was like, okay, now I've picked my pill that I'm going to prescribe. How do I counsel this patient on starting it, right? So there are 3 ways to start. We'll talk about all 3, but the best way to protect in pregnancy is going to be the second option. But 3 seems to be the most popular, I think, just because Sunday start just sticks better in everyone's brain. But the best way to protect against pregnancy is this option 2. So we'll talk about these 3 methods in a minute. I'm going to take a sip of water. All right. Let you read the slide too. All right. So the first way is a quick start. So you have somebody in your practice, you've ruled out pregnancy right away, you've prescribed it, they can start that pill pack that same day. With this method, you do have to use a backup method for at least 7 days, ideally through that first pack, just to make sure that we're giving it time for ovulation to stop. And then day 2, like I said, is going to be the best pregnancy protection. This is when we start the pill pack on day 1 of their menstrual cycle. Remember, we talked about ovulation or menstruation starting. So that's that start of that follicular phase. That's going to be the best way to protect against pregnancy. And you don't have to use a backup method if they're doing it that way. And then option 3, that Sunday start that everybody seems to like, most popular, they're going to start that pill pack on the Sunday after their period. Again, they do need to use a backup method at least for 7 days and through that first pack, again, just to make sure that we've stopped ovulation, right? Because if it's a Sunday after their period, they might be well into that follicular phase, maybe even into ovulation already. So these are the 3 different methods. Take a screenshot of it. Again, these recordings are available to you. You definitely want to make sure you're counseling your patients on how to take it and how to be safe about it so that they're not starting the pill and thinking they're protected. We want to talk about how long they need to be using a backup method for. You also want to manage expectations. When you start patients on these medications, you want to tell them that it's common to see irregular bleeding cycles for the first few months. Don't stop the pill just because of that. It will regulate. All right, talking about progesterone only and the mini pill. I'm just gonna take this sweatshirt off. Sorry, I'm in Texas, so it's still like 90 degrees here. So I'm trying to like temperature regulate with cold water and t-shirts. If you're down in Texas, you know what I'm talking about. All right, my friends. So the mini pill, progesterone only. This does not have any estrogen in it, so it does have less of a risk for those clotting factors or less of a clot risk, but it's a little bit more challenging in certain patient populations, and we'll talk about that. Typically, with this progesterone only pill, I like to prescribe it in my patients who are lactating moms because it doesn't affect their milk supply. But there are huge downsides because it does have that narrow window. So you have to take it at the same time every day for it to be effective. And then you have a 3-hour window. So say the patient takes it at 12 o'clock one day, they have to take it by 3 p.m. the next day. Otherwise, they could start ovulating and they could get pregnant. So it makes it less effective and reduces that protection. So it's not a great option for certain patients, like if they're young and really bad at taking their medications on time. But for our lactating moms, this is a really good option to help protect them even before those cycles really start, if they're already sexually active with their partner, just to make sure that they don't have a second pregnancy before they're ready. It is a less popular option because of that narrow window, but it is still 91% effective if taken correctly. So at the same time every day within that 3-hour window. Then we have our vaginal rings. These are both, most of them have both that estrogen and progesterone option. These are inserted into the vaginal canal. We have different options. We have the typical one, Nuva ring, where you insert it for 3 weeks and then you remove it for 1 week to have that withdrawal bleed. So similar to the pack, when you're taking it orally, they're not ovulating, you want that withdrawal bleed. So they're going to insert it into the vaginal canal for 3 weeks, remove it for that 1 week to have that withdrawal bleed, and then put in a new ring each time. So they're not putting in that same ring, they're putting in a new ring. You also have extended options with the bicycling and the tricycling. Basically, you still have to put in a new ring, but you basically skip that 4th week for 2 cycles, or you skip that 4th week for 3 cycles, so you can extend it a little bit longer. We also have a 1-year ring option. But again, with these patients, you're probably not going to be prescribing this unless you're in a specific practice that does it a lot. And then you want to make sure you're also educating your patients on how to leave the ring in during intercourse and what to do if it falls out. So if it comes out during intercourse or if it falls out, you want to insert a new one within 3 hours. Remember, 3 hours, kind of that magic window. And then if they can't, they do have to use a backup method of birth control. And this is about 91% effective. So it's pretty good. So 9% failure rate. Now we have the patch. So the patch is still a combined hormonal birth control option. So it has that estrogen and progesterone. It does come with a black box warning of a higher risk of developing blood clots because it does have a higher level of estrogen in it because it's on the skin. So it's higher levels of estrogen to make sure that the patient's getting enough estrogen to really stop that ovulation. Placement is going to be really important. You want to educate your patients about placement. So there might be an exam question that pops up about that, because where should you never put this patch? And it's already on the slide, but what do you guys think? Where should you not put this patch because of that estrogen? And you want to make sure patients know about this too. Yes, you guys are rock stars. So engaged, and you're getting them all right. I'm really impressed. So definitely the breast tissue, and why we want to make sure we don't develop any malignancy if we are putting estrogen directly on that breast tissue, right? So we can place it on the upper back, lower abdomen, on the buttocks, on the shoulder, but never, never, never that breast tissue. Similar to the vaginal ring, you're going to wear it for 3 weeks, and then you don't wear it for that 4th week. They typically come in 3 in a pack, so they only have 3 for the month. And then you want to make sure you are replacing it every week, so you're not using that same patch. So you want to talk to patients about that, and of course, talking to them about that higher blood clot risk. So definitely would not be an option if that patient's in that gray area for contraindications. Then we have the injectables, Depo. How many of you have given Depo as a nurse? I know I did as a nurse. I had those patients come in, and this might make me sound really old, but I had that like little wheel that I had to like figure out, do they fall within that 3 months? But how many of you injected patients with Depo as a nurse? I know there have to be some of you out there. No? All right. Well, what is the biggest side effect with Depo? Okay, you've done it as an NP student. Great. What is the biggest side effect or complaint that you've seen from patients who come in regularly for Depo? What is the biggest thing they complain about? And it's on the slide here today too. Yes, very good. So Depo can be a great short-term option. It's progesterone only. It's given every 3 months. This is great for patients who can't tolerate estrogen if they might be at higher risk. Maybe they're breastfeeding moms as well. But it really, and I've seen this firsthand too, it really does cause weight gain. So I know oral contraceptive pills have that negative reputation as well. I don't see it as much with the oral contraceptive pills, and it's not as evidence-based. But with the Depo injections, with the progesterone only, yes, absolutely up to 15 pounds on average. So they will see some weight gain. And also they're going to experience those irregular bleeding as well. That's pretty common with Depo. So patients really don't like it and they don't stick to it. It's not a good long-term option because it also is associated with increased risk of osteoporosis if used for up to 2 years or beyond. So it's really good. It's a good short-term option. It's got about a 6% failure rate. I have to be honest, I don't prescribe Depo very often because I don't really see the benefit. So we have that mini pill for our lactating moms. And then to have a patient come in every 3 months, I saw a lot of young girls in my practice who were missing that window, right? So it's really hard to ask our young females or any patient to really keep coming back in every 3 months for those injections. And so it's not something that's as commonly used anymore. I did see it a lot in my practice when I was an RN, but keep that in mind that compliance is going to be and adherence is going to be pretty tough for these patients. And coupled in with those side effects and those risk factors, I'd be looking at other options. Okay, now let's get into our long-acting reversible contraceptives or LARCs. We're going to talk about IUDs and implants. First one we're going to talk about is the most commonly known as Nexplanon. So this is an implant, also progesterone only. It's a slow release of that progesterone. It's a tiny thin rod about the size of a matchstick. It's approved for about 3 years, but they're evaluating it to see if they can keep it in for 5 years and maintain efficacy. Some really big downsides to Nexplanon. First of all, you do have to be certified by the manufacturer to be able to implant it and explant it. So you can't just do it in an outpatient setting that doesn't have this available to you or have providers who are certified. So they have to go to a separate place or an OBGYN practice. Other big cons, so insertion of that site scar is real. When you take it out or even when you put it in, the patients can still feel that rod and really don't like that. And it does, because it's progesterone only, does cause that irregular bleeding. So how many of you have seen insertion or explant of the Nexplanon in either your rotations or your clinical settings as a nurse or nurse practitioner student? How many of you have seen this? And how many of you have felt the Nexplanon under the skin? Yeah, some of you. Yeah, and I remember, so I'm not certified, but I certainly worked in a practice where there were certified providers. And so I have to be honest, it's not as graceful of a certification as I thought it was going to be. And so that insertion site scar is real, and you can definitely feel the rod. And when it's explanted, the scar really does stay. So it's something to talk to patients about and make sure they're okay with if you're going to proceed with this option. Yeah, so some of you have seen this in your clinical practice, so you know what I'm talking about. Now let's talk about our intrauterine devices, or our IUDs. So these are also tiny little devices that we put into the uterus. It looks like a T right here. So that sits in our uterus. And then those two little strings come out of the cervix. So even if you're not the one inserting it, you might be doing a pelvic exam in an outpatient setting where a patient's had an IUD placed by another provider. What I like to do is make sure, and this is the way I was taught, but make sure I note that I can see both the strings when I'm doing my pelvic exam. That's going to be really important, because one of the risks for IUDs is expulsion and migration. It's pretty rare, but you want to make sure that you can see those two strings, so that it really hasn't migrated up further into the uterus and causing perforation and other problems. It does not prevent ovulation. So what I really like about IUDs is once it's removed, patient can theoretically get pregnant right away. So it really does not disrupt that ovulation. So it's a really nice option for some patients who don't have any plans of being pregnant in the near term, but they might want to get pregnant right away once they decide to remove the IUD. So I always like that. Some of them, we have hormonal and non-hormonal options. So some of them act as a physical barrier, while others act as a chemical barrier, and we'll talk about that, but they're really, really effective in preventing pregnancy. So they're long-term options, they're reversible, and one of the most effective birth control methods out there. So that might be something that'll clue you on an exam question. What is the most effective option for this patient? If there's an IUD in there, that's going to be your most effective. So less than 1% failure rate. They're great. Other things that we want to talk about, some contraindications. So you can't use it in patients that have any kind of anatomical abnormality, so cervical or uterine abnormality. If they've had a history of pelvic inflammatory disease or ectopic pregnancy, that does increase that risk of the migration expulsion. So it's also contraindicated for those patients. But really, really great options. How many of you have seen the insertion of IUDs in your clinical practice or in your training? Yeah, definitely. You've explanted it in the OR with the next one. I see that, Abigail. In the OR. That's interesting. So the reason why I ask is because we'll get to this in a minute, but the insertion, you definitely want to make sure, even if you're not inserting it, you're talking to patients about talking to the provider about providing anesthesia, because it can be very painful. Now let's start by talking about the Paragard. This is our non-hormonal IUD option. I really like the Paragard, but I will give you my 2 cents about it and the lesson I learned as a new clinician. So Paragard is a non-hormonal option. We also call it the copper IUD. It works by physically preventing, it's a physical barrier to preventing pregnancy. It changes the pH of the uterus and makes it more hostile to sperm. It's good for up to 10 years, so it's great. Biggest issue, most commonly reported side effect with Paragard. What is it? Do you guys know? Have you experienced it? Have you read about it? Do you know about it? This is very real. Yes, bleeding. So worsens those periods. Bleeding is a big one. So causes cramping, flow length to extend. It's real. And so I'll tell you my 2 cents entering into clinical practice. I had a patient. This was a really good option for them. It fit all the boxes. They didn't want to get pregnant for a long time, but wanted to be reversible. Didn't like the hormonal options. I said, great, copper IUD. I was not certified, sent them over to another provider. They had it, they got it in, great. This patient then proceeded to come in and say, oh my gosh, the bleeding. And it didn't matter how much on the back end we talked to them about the bleeding, about how it does improve over 3 to 6 months. They eventually then had the copper IUD removed. So that was a huge lesson for me, because you definitely want to make sure you're talking to these patients about these side effects, these potential side effects, before they go through all of that. Because first, it does help with adherence. So that patient, if they had known beforehand and they had made that decision beforehand, knowing what was to be expected and what to come, they might have left that copper IUD in, right? But once you're working kind of on the back end, then it's harder to get that patient to really stick it out. And it wasn't just me, right? They went to even another provider provider who did the implantation. They didn't even talk to them about the side effects, and this patient came in totally blindsided. And so it really taught me it doesn't even matter if I'm the one doing the procedure. If I'm making the recommendation, you're going to be talking to your patients about all of this. You want to spend the time and really educate them on it, because you don't know what the visit with the other provider or the specialist is going to be like, and you want to make sure that they know everything going into it so that it's more successful and it really helps them stick it out and be adherent to the contraceptive method. So that was my 2 cents with the copper IUD. I've learned my lessons since then, so I really do talk to my patients about this method, and it is a great method if we're looking for non-hormonal IUD options. Now let's talk about our hormonal progesterone only. We do have different types. We have the Mirena and Skyla, and it just depends on the level of the progesterone in there. So with the Mirena, slightly higher level of progesterone, so that's why it can be placed and stay in longer for up to 7 years. Typically, patients do change it out a little bit sooner than that because of the bleeding. And then you have the Skyla with lower hormonal levels. Pros and cons to our hormonal IUD. So it does help control those heavier Menses cycles. So in patients who may also have that as a problem, hormonal IUD may be a better option for them. And then there are less side effects than taking an oral contraceptive pill. Some cons, we talked about that risk of expulsion and migration. And then this is what I was getting at with the insertion of the IUD. So if you've ever watched one, this is what made me realize that I never want to get certified in inserting IUDs. They are highly painful. So you want to make sure you talk to patients about this so that they can talk to the provider about their anesthesia options. So typically they should be doing a nerve block around the cervix before they do an insertion, but you want to make sure you talk to patients about that so it's not a horrible experience for them. Okay. So those are all our options. I know it was a lot. We went through it kind of fast, and I'm mindful of the time because we haven't even gotten into prenatal care. But let's do a practice question together. So how might it pop up on the boards? A 16-year-old female presents to discuss birth control options now that she is sexually active. She reports that she doesn't take any medications other than vitamins. She forgets to take sometimes. So she's not really compliant with taking something every day. Which of the following methods is the most effective for her to recommend to her? Is it A, B, C, or D? What do you guys think? Absolutely. Yeah. And so so obviously the IUD, that intrauterine device, is going to be the most effective for her. She doesn't have to think about it. She's not planning on getting pregnant anytime soon. She's 16 years old. What do we need to educate this patient on once she gets the IUD or is planning on getting IUD for contraception? What do we need to make sure she knows that she's not protected against? Absolutely, yes. So she's still not protected against STIs. So this is just for contraception, right? We still want to talk to her about making sure she's using a barrier method as an additive to make sure she's protecting herself against STIs. Very, very good. Oral contraceptive pills, again, requires consistency, so may not be the best option for our adolescents. Vaginal rings, kind of similar thing. Failure rate's also a little bit higher, so still not the best option for her. And then same with that depot, she does have to come back in every 3 months, so she might not be compliant with the treatment. Awesome job, you guys. All right, so before we jump into prenatal care, I was going to ask you guys how comfortable you feel about what we just talked about with contraceptives now, having started the day with not reviewing it, and now after going through the presentation on a scale of 1 to 10, how comfortable are we feeling now? More, less? All right, I'm seeing some more comfort levels. That's great. So now we'll go through prenatal signs, prenatal care. I know we have about 10 minutes left in today's lecture, and I think I just get a little chatty sometimes. And what I'll do is if we don't have time for everything, I will go through these slides so that you'll have it on the video, and then I'll just plan to do another webinar for you guys just for the prenatal care. But basically for the boards, they'd like to ask questions about these pregnancy signs. So looking into knowing those the Hagar sign, the Chadwick sign, Goodall sign. That's going to be helpful for you to know that your patient is pregnant. Sometimes you might have patients coming in who've taken a home pregnancy test, a urine pregnancy test, and asking for a blood test. They just need the reassurance and they're in denial about being pregnant. So be gentle with them. I did that. I had a patient who did that. So it's just, you want to be gentle with those patients. You also might have patients coming in saying, I haven't had my period. I'm feeling nauseous, fatigue, tender breasts. And then of course we can confirm the pregnancy with that fetal heart tone and that ultrasound of the fetus. Nigel's rule, you can take a screenshot of this. It's basically a way to estimate that due date. We are going to confirm that with the ultrasound. This is our prenatal testing. So oftentimes you have patients who know and are planning on getting pregnant. They might go through the genetic screening beforehand just to see what they're carriers for, or if they have a family history that they're concerned about. Early pregnancy, you do need to know this for your boards about what you're offering at which trimesters, because this is something that can typically fall in your wheelhouse depending on the patient population that you're serving. When I worked in a federally qualified healthcare center, certainly the primary care providers did the prenatal care, and then they rotated through the prenatal clinic about once in a while just to make sure that they're hitting all their check marks. But in early pregnancy, we want to make sure we're screening STIs. We're catching any thyroid abnormalities. Why with thyroid, you guys? Do you know what happens in pregnancy with thyroid? I'm challenging you guys today, I know. That's a good guess, Abigail. So the fetus itself actually doesn't start producing its own thyroid hormone until about 12, at least the first trimester, well into the second trimester. So if we have any thyroid abnormalities, we definitely need to be supporting those moms early on in that pregnancy and pretty frequently. So we need to see them pretty often and checking those thyroid levels pretty often. So that's why we want to make sure we're catching it early in that pregnancy with those screenings. Urine, why are we checking urine? Why are we checking urine? And if you've been pregnant, you know that your OB is going to have you leave urine at every visit. Yeah, we definitely want proteinuria is a good guess. Yeah, we want to catch those infections and treat those infections even if they're asymptomatic to help protect that fetus development, right? Very good. And then CBC, we're looking for anemia. We're going to also do those RH titers. And then we're also going to do various genetic screenings throughout the process. And it also depends on your state and what you're going to offer to your patients for genetic screening. Right around the 18 to 20 week mark, we're going to do that anatomy scan. I've had 2 kids of my own, and it's really nice for parents to go through that anatomy scan because it's really the first time where you get to see all the parts of baby. And then we're going to screen later in that second trimester for gestational diabetes. And the reason for that, do you guys know? Have you heard my diabetes lecture? Why are we testing towards the end of the second trimester for gestational diabetes and not in the beginning? Challenging you guys today. I'm sorry, I feel mean. All right, so we're testing for that because yeah, the pathophysiology. Good answer, Abigail. So the reason for that is because mom's body is really insulin sensitive in the beginning because it's helping support that the maternal growth. But then as the baby, the fetus starts to grow, so as it shifts into second trimester and it's really baby's turn to really grow, the body, mom's body actually becomes insulin resistant. So it shifts a little bit. And some of our moms have trouble with that insulin resistance and they develop that gestational diabetes. And that's when we have to help them to make sure we're supporting that fetal growth as well. So that's why we don't really do it till later in the pregnancies and the trimesters. And then group B strep, we always want to make sure we're screening. And then if mom is group B positive during labor, they're going to receive antibiotics. And then around that 20 weeks, 28 weeks as well, they're going to get RhoGAM if mom's maternal blood type is RH negative. And that's again to protect the fetus and make sure that mom's body is not attacking the fetus. All right, that was fast. I'm sorry. I know I plan to have a lot more time. So let's do this last practice question, and then I'm going to give you the slides, and then we'll open it up to a Q&A. But a patient is in for a routine prenatal visit at 12 weeks, so they're still in that towards the end of that first trimester. She had her routine blood work already at her first prenatal visit at 8 weeks, and the ultrasound has already confirmed that intrauterine pregnancy and gestational age. So she's gone through those steps. They're telling you that. She denies vaginal bleeding, urinary complaints, nausea, vomiting, and abdominal pain. So she's feeling well. Based on the findings, which of the following would be a routine order for this visit? So are you checking those Rh antibody titers? Are you doing a 1-hour glucola test? Are you doing a transvaginal ultrasound? Or are you doing D, a urine culture? What do you guys think? Ooh, I like it. I like it when the answers are across the board because then we can talk through them. So that's great. Okay, so the answer is D. So we're going to be doing a urine culture test for this patient. Again, we want to screen for that asymptomatic bacteriuria because we want to make sure we're preventing the complications like premature labor. Why are we not doing the titers? Because it's already telling you that she's had that first prenatal visit. So you know that first prenatal visit is going to be checking those Rh titers, right? And then we're not going to do the 1-hour glucola testing this early on at 12 weeks because it's not really going to help us in diagnosing and identifying gestational diabetes when mom's body becomes more insulin sensitive towards the end of that second trimester. And then transvaginal ultrasound, she's already had an ultrasound and it's already confirmed the intrauterine pregnancy. So we're not going to do something invasive like a transvaginal ultrasound. That's not helpful to her. It's not helpful to anyone. We're just going to be checking the fetal heart rate at this visit. And then at every visit, we're really going to be checking that urine culture to make sure we're ruling out any infection and we're treating it, even if mom is asymptomatic. Awesome, awesome job, you guys. The other thing I want you to know is about fundal height. The way I like to remember fundal height is 40 weeks of gestation. Halfway point is right around the halfway point on your stomach, your umbilicus. So that's a fun way to remember the fundal height. Normal body changes. So again, remember the normal versus the abnormal. Mom's going to gain weight. 25 to 35 pounds is normal weight gain, healthy weight gain. She might have some extra heart sounds just because of that increased blood volume during pregnancy, some constipation you'll have to talk about. Melasma is when you get those dark patches and spots on the face, reassuring mom that they do resolve once baby is born. Abnormal findings, we definitely want to make sure you're looking at these slides. So placenta previa, that's when these are all going to be complications that we're talking about after 20 weeks of gestation. So remember, light bleeding and spotting is normal in those first trimester. Up to 25% of women experience some sort of vaginal bleeding, but we're talking about bleeding after 20 weeks. So placenta previa is when that placenta implants in that lower uterus instead of the upper uterus. And there are a lot of different reasons, but we want to definitely evaluate bleeding in that past that 20-week mark. So we have placenta previa. We also have placenta abrupta, where that placenta starts to detach. And this is going to be more dark, painful bleeding because you're going to get that uterine rigidity. The uterus is going to try to grab onto that placenta and other complications that come from that. And then you have preeclampsia and eclampsia. We didn't really get into this today, but basically preeclampsia, again, after 20 weeks of gestation, is new onset hypertension. So a blood pressure over 140/90, along with that proteinuria, because that's going to be the first sign of kidney disease or kidney injury, I should say. The cause is unclear, but they suspect, or research suspects, that it is due to an abnormal developing fetus. So there's a lot of vasoconstriction and retention of salt in the kidneys causing that hypertension. And it affects a lot of different organs, not just the kidneys, but also the brain, the liver, the eyes. That's why you see the host of the symptoms. So patients get elevated LFTs, blurriness in the eyes, edema, not just in the lower legs, but they can get pulmonary edema, and that's what we worry about with the headaches, shortness of breath with cerebral edema, so a whole host of complications. And eclampsia is just when they then do also develop seizures. So knowing these complications help is syndrome that happens in about 10 to 20% of these women with preeclampsia and eclampsia. So all these really are medical emergencies that we want to prevent and making sure we keep moms safe during pregnancy. Medications to avoid during pregnancy, take screenshots of this. no to NSAIDs, ACEs and ARBs, fluoroquinolones, Bactrim. These are really important because if you're treating those asymptomatic UTIs, you want to make sure you're using something like Keflex, telling mom that she needs to use Tylenol instead of over-the-counter NSAIDs. We definitely want to make sure if we're treating someone for hypertension, we know about their family planning. And if they are planning a family in the near term, we are putting them on a different agent as opposed to those ACEs and ARBs, and then educating our patients who are on ACEs and ARBs to make sure that if they change their mind and they're going to be planning a pregnancy, we need to change their hypertensive medications. Codeine, benzos, I never prescribe in pregnancy. You can send them over to pain management if they really want something, but anxiety is really common in pregnancy, and the antihistamine hydroxyzine is really effective. But this is going to get a little bit more complicated, go to our specialist, but know that these are contraindicated in pregnancy, so warfarin and Accutane. So if you saw my lecture last week about Accutane, you know it's highly tetragenic. All right, you guys, last practice question with 1 minute left. A 26-year-old patient with chronic hypertension presents for an annual gynecologic exam and is planning for contraception in the next 6 months. Nurse practitioner reviews her current medications during preconception planning and identifies the need to transition one of her medications to one with a better safety profile for future pregnancy. Which of the following medications is concerned? So what did we just talk about? Is it A, B, C, or D? Go ahead, put it in the chat for me. Yes. Yes. You guys are listening. You're going to be safe providers. I know it. You guys are going to do awesome, not only for your boards, but when you enter clinical practice. So we want to avoid those ACEs and ARBs. Definitely, she's okay on the labetalol and difenadine. Hydrochlorothiazide's okay too, but we do not want her on that ACE. Awesome job, you guys. Okay, I know I didn't give us very much time for Q&A at the end. I apologize. I think I talked a little more slowly than I usually do today. I blame the heat. I'm sorry. Go ahead and join our Facebook group and get the recording of this lecture, which will include all the slides and everything we talked about, all those great QBank questions. Try our QBank for free. If you haven't tried it, that's where these questions came from, and we have a lot of them. You can search by topic. It'll give you that readiness predictor. Join us for our next 3-day live review in November. I'd love to see you there. Our SurePass gives you all of it bundled together, and we have SurePass Pro with that mentoring in that package as well. All right, you guys, thank you so much for joining me today. Oh, and Lena, you passed. Yay! That's awesome. I had no doubts, Lena, that you were going to pass based on your responses in our last webinar. So I'm so glad to see. Thank you for giving me an update. And remember that we also help mentor you into your first clinical practice. And we have a lot of CE stuff coming up too for our nurse practitioners. So make sure you join our Facebook page and you continue to follow us. And as these things unfold for you as a provider, there's going to be a lot of free content for you. So I know you're going to there's a lot of expenses that come with getting into clinical practice and finishing up school. So make sure that you don't miss out on that free content. But that's awesome. So excited for you guys. All right. Well, thank you again for joining me today, and we will see you on the next webinar. Have a wonderful day.